Hi, this is Lindsay Luther. This presentation is going to talk about common complaints associated with pregnancy. The first complaint that women will present to your clinic with often is fatigue. This may actually be one of the first signs of an undiagnosed pregnancy after a missed period, especially if a woman has irregular cycles. Fatigue peaks in the first trimester as progesterone levels rise, and this can be one of those first signs of pregnancy. It can be a very challenging experience, especially for women who are working, especially working long hours or who are trying to care for other children in their home. That fatigue starts because of changing hormone levels, but then is exacerbated by increased blood volume. So the woman's blood volume will increase significantly during pregnancy, and this leads to higher respiratory rates and cardiac heart rates, and eventually increases the cardiac workload. As the blood volume increases, iron production takes a little bit longer to catch up, and this results in what we call a physiologic anemia. So the woman is anemic, but not because she's not making enough iron, but because the blood volume has increased disproportionately to iron increases. This will resolve itself in most cases over time and is considered physiologically normal. Fatigue mostly gets better at the end of the first trimester, and women typically say that they feel better in the second trimester, but later on in pregnancy, that fatigue will come back. And this is often because women have increased discomfort, their hormones shift again, and then there's a physical strain of the developing fetus. So there is discomfort while sleeping. There's also sleep disruption, which is part hormonal and part physical discomfort. And then obviously, carrying around the weight of a later pregnancy can be challenging. Nausea and vomiting is a very common complaint, especially in early pregnancy, but for some women it can last longer, and that may indicate a hyperemesis gravidarum, which is it's not necessarily a pathology, but it can be quite problematic for a woman. So younger women, those who are having their first pregnancies, and those who have very sensitive senses of taste and smell have a higher risk of nausea and vomiting. The nausea is caused by high levels of progesterone, but it can also be caused by a lack of thyroid hormone. So women should be checked for subclinical hypothyroidism in pregnancy, especially if they're tremendously nauseous. Beta HCG levels contribute to nausea as well. And at the far end of the severity spectrum is hyperemesis gravidarum. So nausea and vomiting is actually a healthy sign of pregnancy. Women who have adequate estrogen, beta HCG levels will tend to be more nauseated. So women who have more nausea and vomiting during pregnancy are actually at a lower risk of miscarriage, and they typically have better outcomes overall as far as delivery of a healthy baby. However, if the symptoms are very severe or prolonged, this can lead to inadequate hydration or problems with dietary intake and nutritional deficiencies. So when it comes to nausea and vomiting, you're going to decide who needs treatment as opposed to just behavioral modifications based on the way that the nausea and vomiting presents. So there's three categories of nausea vomiting. There's nausea alone, there is vomiting but without hypovolemia, so without fluid imbalance, and then there's vomiting with hypovolemia. If a woman is having volume depletion because of vomiting, they can have complications including electrolyte abnormalities, vitamin deficiencies, and excessive weight loss. Women also need to be assessed for the impact of their symptoms on their daily function and their quality of life. It can be tremendously disruptive to have nausea and vomiting to the point where it can actually lead to a woman feeling depressed or increased anxiety or feeling like she can't function with her day-to-day life. And obviously, if quality of life is that impaired, then treatment should be offered. So first of all, if there is hypovolemia, then obviously we're going to approach that first. So if the volume is low, then the patient needs to probably go to the emergency room so that they can be treated with antiemetics and be fluid resuscitated. First line, though, if a patient is having nausea and vomiting without hypovolemia, is behavioral modification. So if there are certain foods that trigger this, then you should avoid those foods. Other behavior modifications include eating a small snack like some crackers before getting up in the morning, avoiding strong smells, drinking fluids separately from meals so that they are able to keep food down, and then using ginger, so ginger tea or ginger supplements. Acupuncture has been reported moderately effective in some small, low quality studies. And then pharmacologic therapy can include B6. There are also some antihistamines that can be used, H1 blockers, as the second line. So things like doxylamine peroxidine, diphenhydramine. So B6 is an over-the-counter available supplement, and a half a doxylamine tab or a Unisom tab is also available over the counter. If you can certainly teach women how to make these over the counter if you would rather do that than offer a prescription, since the prescription can be more expensive. If the B6 and diclejus doesn't work, then the second line is those antihistamines. You can add meclizines. Promethazine and prochlorperazine are offered via rectum, so that's an option if women can't even keep the pill down long enough. Ondansetron or Zofran can be used. However, there have been some reports of cleft defects, so cleft lip, cleft palate with that use, but there have been some larger studies since then that have shown some reassuring evidence that this is a very low relative risk. And so it's not necessarily precluded. You can use those if you need to. And then if you are going to use Zofran, though, the patient needs to be monitored with their ECG to make sure that they're not having QT prolongation. Okay, so on that far end of the spectrum of hyperemesis, this is severe nausea and vomiting at least 3 to 4 times a day, ultimately resulting in either dehydration, electrolyte abnormalities, or a weight loss of over 10 pounds. So when these patients come in, they are going to need to have their weight checked. They're going to need orthostatic blood pressures to make sure that they're not, getting dizzy when they first get up. You may want to check their electrolytes and urine ketones to check for dehydration, as well as urine-specific gravity. And then an ultrasound might be useful in checking to make sure that the patient is not actually pregnant with multiple pregnancies or that she doesn't have gestational trophoblastic disease. There are some risk factors for HG, including being a first-time mom, being overweight prior to pregnancy, having multiple pregnancies, multiple gestation, or a history of hyperemesis during a previous pregnancy. Treatment for this is the same as in other nausea and vomiting, but includes management of dehydration. And the patient may need some IV anti-nausea medication and IV fluid and electrolyte replacement. The mom needs to be watched for monitoring of her weight as well as fetal growth, and then maternal mental health should be assessed as well, because this can be very, very challenging to deal with for months and months at a time. Another common complaint is rhinitis or seasonal or nasal allergies. So there is a specific type of stuffy nose that is associated with pregnancy. So rhinitis of pregnancy will occur in about 30% of pregnant women, and this is due to hyperemia and edema of the nasopharynx. This is diagnosed when the symptoms last for more than 6 weeks, but there's no obvious source of infection or allergic causes. So the rhinitis that a woman experiences in pregnancy may be due to the pregnancy, or it could just be that she's always had seasonal or allergic rhinitis. And so if the patient has a pre-existing allergy, the symptoms can worsen, improve, or remain the same. There are many treatments that a woman can use that are considered safe, and these include nasal sprays, oral antihistamines, and they can use intranasal decongestants as well, but those should be limited to 3 days or you can have rebound congestion. Headaches. So headaches are common pretty much throughout childbearing years, but this can worsen in pregnancy, again, because of increasing hormones, and this is especially true for migraines. So the primary goal in a woman who is pregnant who has headaches is to rule out, number 1, preeclampsia, and number 2, a serious underlying disorder. So you will learn more about headaches as we move into our neurology and HE&T section in a few weeks. But preeclampsia is a complication of pregnancy that occurs in the second half of a pregnancy, so after 20 weeks gestation. It's diagnosed when there is a high blood pressure, so over 140 or over 90, plus one of the following: protein in the urine, high platelets or creatinine, high liver transaminases, pulmonary edema, or the presence of cerebral or visual symptoms. So we want to make sure that the headache is not one of those cerebral or visual symptoms accompanying the high blood pressure, in which case the woman would meet the criteria for preeclampsia. Serious underlying disorders are the same things that cause those thunderclap headaches. Or those other headaches that concern us in just broadly in adults. So, for example, if the headache is associated with the changes in mental status or neurologic changes, things like a stiff neck or photophobia, papilledema, or if it is that sudden severe thunderclap, if they're having a migraine for the first time in their life and they've never experienced migraines before, if they have immunosuppression, for example, if they're on steroids for any reason, or they have a fever, we would be more concerned about meningitis or encephalitis. If there's been any trauma to the head, or if that headache is just severe and unrelenting, those are signs of a more serious disorder. So when you're evaluating the headache, you're going to ask questions such as, have you had this type of headache before? And if you have, or, if you haven't, is it one of those things? Does it have those associated symptoms like those that I just read that might indicate a neurologic problem? These are going to help you rule out serious underlying disorders. If the patient is not hypertensive, then it is not preeclampsia. So you can rule that one out pretty quickly. And then from there, you're going to go on just trying to diagnose the headache as you would otherwise. If it's one of those severe concerning disorder headaches, you might proceed with an MRI or a head CT. You might be wondering about radiation exposure in pregnancy. Head CT is considered acceptably safe because the radiation exposure is limited mostly to the head and can be kept pretty decently far away from the developing fetus. A lumbar puncture is also a safe workup for a headache. So treatment, it's going to depend on the type of headache. So the two most common types are migraines and tension headaches. In pregnancy, first-line treatment is always going to be acetaminophen. You may think that you may not be able to use NSAIDs in pregnancy. This is not actually true. You can use them, you just cannot use them in the first trimester. So after the first trimester, a second-line treatment is NSAIDs for both migraine and tension headaches. Aspirin can also be used to treat migraines after the first trimester. And then third-line, opiates can be used if necessary, but you want to use these for a short amount of time. Triptans can be used for migraine abortion in pregnancy. However, you don't want to use them, again, too often, or you can get rebound headaches. You can consider adding H1 antagonists and Zofran if there's nausea and vomiting that comes with the migraine. You can use beta blockers and calcium channel blockers for prevention of migraines. You absolutely cannot use ergotamines or isometheptine. Sorry, that one's hard to say. In pregnancy, they are prohibited. So tension headaches, pretty much the same. Third line, though, is going to be acetaminophen plus caffeine, and then butalbital is an alternative. You may know Furosemide. All right, another common complaint moving on to is pelvic pain. So when I talk about pelvic pain in this section, I'm speaking specifically about musculoskeletal pain of the pelvis. Typically, this is located at either the symphysis pubis, the SI joints. It may be experienced kind of in the perineal area or in the lateral side of the low back, kind of on those, the tuberosities of the femur. In it, you can also have some pain in between your thighs. So most women will say that this gets worse when they walk, stand on one leg, for example, when they're going up and down the stairs, or if they try to open their legs apart, for example, when they're getting out of the car or when they're rolling over in bed. Those are the things that make it worse. Their physical exam will be consistent with a normal pregnancy, except that they will also have a reproducible pain. So they can usually tell you what causes the pain. Treatment involves supportive devices. So, for example, a belly band or a pregnancy support device, which is kind of like a back brace with a front that lifts the belly up. Physical therapy can be very helpful. Some women may need crutches as extra support for their weight during pregnancy. And then women may need to limit activity. So if they're working full time and that involves walking and standing for prolonged periods, they may need to consider reducing activity a little bit to make it more tolerable. This is actually why I stopped working at the end of my second pregnancy, is because at the end of the day, I was having such bad SI pain that even with physical therapy and a support band, I would come home from work and I would just have to lay on the couch for 5 or 6 hours because I couldn't stand up anymore. All right, itching. Okay, so there's different types of itching in pregnancy. As usual, when we're thinking about itching, we're thinking about what is this most likely to be? What is another common thing that it could be? And then what is something that we need to be very careful about? So, abdominal itching, if the itching is just on the belly and there's no associated rash and there's no other symptoms, then it is probably just related to stretching of the skin. If there is a rash on that is associated with it, it is most likely to be PUP or PUPS, which stands for pruritic urticarial papules and plaques of pregnancy. And this is a rash that is the most common skin condition that pregnant women experience. It has had multiple names over the course of medicine, but now we call it PUPS. It typically starts in the third trimester, and it starts as a rash kind of around the belly button, but not directly next to the belly button, and it spreads outward across the chest and the arms and the legs. It usually will not affect that directly periumbilical area or the palms of the hands or the soles of the feet. We're not entirely sure what causes this rash, but women who gain a significant amount of weight very quickly or who have multiples are more likely to have this rash. And then it usually goes away within 15 days of birth. However, it can be extraordinarily uncomfortable in the meantime. And so you want to help women with symptom relief, and you can do that with topical corticosteroids, oral antihistamines, or even a short course of systemic steroids, glucocorticoids, if they are tremendously miserable. The one thing we have to rule out with itching is cholestasis of pregnancy. So this will cause intense diffuse, so across the entire body, itching, but there will be no rash associated with it. The hands, the palms of the hands and the soles of the feet may itch most, which is the other thing that will distinguish it from PUPS. And then it may have jaundice, nausea, vomiting, anorexia associated with it. This can be problematic because it can result in vitamin K deficiency, a clotting deficiency in the fetus, as well as preterm delivery or stillbirth. So we do need to be very careful about this and make sure that we refer these women to be potentially delivered before this gets worse. Okay, abdominal pain is a big topic. So most women will have some amount of abdominal pain during pregnancy. Those that we would say are common are the things that are up here in the upper left corner here, the benign pregnancy-related conditions. So these are things like round ligament pain, which is stretching of the round ligaments that anchor the uterus during pregnancy. Gas pain, because there's gas bubbles can get trapped because the intestines are sort of wrapped around or compressed by the uterus. Constipation for the same reason, in addition to the fact that progesterone slows movement through the GI tract. Braxton Hicks contractions can be uncomfortable. They're not usually described as painful. And then just the growing uterus can cause pain as it pulls and stretches the abdominal muscles and it may make for awkward movement of the pregnant woman, which ultimately causes some discomfort in the belly. There are some warning signs that are associated with pregnancy-related abdominal pain, and these are the presence of fever, chills, nausea, vomiting, vaginal discharge or bleeding. If it's cyclical or progressive, that may indicate the onset of labor. If it doesn't improve with rest, it is unlikely to be a Braxton Hicks-like contraction and is more likely to be a regular contraction. And if it impairs the ability to function normally. So of all the things that we get concerned about, we can separate them into things that are related to the pregnancy and things that are not related to the pregnancy. One of the hard things about pregnancy is that unfortunately, all of the abdominal things that can happen that need to be treated can still happen in a pregnant woman, but then there's also the things that are specifically related to the pregnancy. The goal of the primary care provider then is basically to rule out any complication of the pregnancy and then rule out any treatable abdominal illness. So your job is going to be to start with a thorough history and physical like you would with any other abdominal problem, and then order testing that you think will help rule in or rule out those diagnoses. All right, vaginal bleeding is actually really common. This is something that you will probably encounter if you work with pregnant women. It usually comes from the maternal blood source rather than the fetal blood source. In the first trimester, the most common causes are ectopic pregnancy, miscarriage, and then pelvic pathology. Miscarriage can be classified as threatened, inevitable, incomplete, or complete, and it is the most common cause of bleeding in the first trimester. But ectopic pregnancy is the thing that needs to be at the forefront of your mind because it is the can't miss diagnosis of first trimester bleeding. Ectopic pregnancy will cause life-threatening complications in the mother. Miscarriage is unlikely to cause significant bleeding to the extent that it would lead to hemodynamic instability in the mother. Between 13 and 20 weeks, ectopic pregnancy becomes far, far, far less common because usually these will come to a head in the first trimester and not progress to the second trimester, or they get caught by ultrasound, or they will start to rupture before the 13th week. Miscarriage can occur, but is also less likely. The pathologies associated with either pregnancy or with the pelvic organs are more common causes. And then after 20 weeks, we really start to worry about the late complications of pregnancy. So things like placenta previa, placental abruption, uterine rupture, and vasa previa. So in case you're not familiar, placental abruption is when the normally implanted placenta starts to separate from the wall of the uterus before delivery. This should only happen after the baby is born. Placenta previa is when part of the placenta is implanted over the cervical os. So as the cervical os starts to dilate, it actually pulls the placenta away from the uterus and can lead to bleeding. And then finally, vasa previa is when there are fetal membranes that cover the internal cervical os. So the approach to vaginal bleeding is very similar as it is in other things. First, we're going to look at amount, pain, always whether or not the woman is stable in terms of hemodynamics and fluid status. If the woman is passing any tissue, that will give you clues about whether or not this is likely to be a miscarriage. And then it's always helpful to know the person's medical, surgical, and pregnancy history so that you can make sure that that doesn't give you clues. Physical exam is going to be, again, related to hemodynamic stability. You want to check an abdominal exam first. You do not want to do a speculum exam if you're concerned about things like placenta previa. You want to make sure that that's not what it is before you start entering into the vagina and the cervix. So abdominal exam can be done with percussion. Primarily, it's easier than palpation in pregnancy. You can check the uterine size to make sure that it's appropriate for the gestational age and also the fetal heart tones. And then a transvaginal abdominal ultrasound can be helpful, and then quantitative beta HCGs can be helpful. Okay, couple other complaints that we see frequently are wrist pain, and this is usually caused by carpal tunnel syndrome or de Quervain's tenosynovitis. Carpal tunnel syndrome can happen across the lifespan. It's very common in pregnancy because of increased fluid volume and also hormone changes in pregnancy. This results in compression of the median nerve in the wrist, and that results in numbness, tingling, and pain, especially of the first 3 fingers of the hand. And this pain can actually extend up to the elbow. De Quervain's tenosynovitis is a pain at the base of the thumb. If you remember from advanced assessment, Finkelstein's test can be used to assess for this disorder. This actually occurs most commonly just after pregnancy in women who are breastfeeding. And that's because these women tend to have high prolactin levels, which somehow contributes to de Quervain's. And they also have repetitive lifting, for example, lifting a baby out of a crib or off of a changing table, things like that. Medication can be used, such as over-the-counter painkillers. Injections into the area of tenderness at the de Quervain's tenosynovitis area can help. And surgical release can be performed if conservative treatment fails. Okay. Vulvar and vaginal discomfort, again, very common. Women can have significant swelling. They can also suffer from things like vaginitis or varicosities during pregnancy. So your plan of care is going to be assessment, diagnosis, and then treatment of the underlying disorder. Anxiety and depression are super common in pregnancy and may either pre-exist it or begin during the pregnancy. And both of these things, anxiety and depression, are associated with adverse neonatal outcomes. The role of the primary care provider is to assess, diagnose, and treat. There is some mixed evidence regarding medication. So SSRIs do have some perinatal risks. For example, they are known to slightly increase the risk of birth defects and also potentiate preterm labor. Using these in the third trimester has been correlated with the risk of infant pulmonary hypertension, which it still happens really rarely. So overall, the risk is low, and most providers think we need additional research to kind of quantify these risks better. Regardless, though, the American Psychological Society and ACOG recommend that women consider tapering SSRI medications prior to pregnancy if the woman's doing well, but those who wish to continue them can do so under the supervision of the prescriber and the perinatal provider. And then women with severe anxiety and depression should absolutely stay on their medication as long as it's pregnancy safe, because again, anxiety and depression also can cause adverse effects in the perinatal period for the infant and the mother. Okay, last thing we're going to talk about today is PICA. So for those of you who are not familiar with it, PICA is a craving for or an intentional consumption of non-food substances. And there's 3 types of this. The typical things that people eat are raw starches, earth materials, and ice. So we don't really know why women do this. It can happen in children, it can happen in men as well, but women in pregnancy are more likely to do this. We think that it may have something to do with a micronutrient deficiency, such as iron, zinc, or selenium. And then some may do this because it's protective of the GI tract. Either it prevents absorption of other things that distress the GI tract, or it can relieve symptoms. So it's important that pregnant women be screened at the first prenatal visit and then at least once in the subsequent trimesters to see if they are engaging in PICA behavior. And if so, they should be reassured that it's common. A thorough history and physical should be performed to identify the severity and how long it's been going on. And then the woman should be examined for any potential sequela of this behavior. Consequences might include anemia, poor weight gain of the mother and fetus, or excess weight gain of the mother and fetus, nutritional deficiencies. It may impair the use of medications that the woman is being prescribed or that needed. And so that can be a consideration. And then you want to look for things like electrolyte abnormalities or GI damage or tooth damage. It can be helpful to do a CBC or iron binding studies to make sure that there's no anemia as a result. And then treatment is typically just going to resolve around educating the woman and helping her to develop a harm reduction plan. So reducing the amount or the frequency of these substances being ingested can help. Okay, so that's the end of our common complaints of pregnancy. If you have any questions, please feel free to post them to the 24/7 office hours discussion board, and we will see you in class to talk all about pregnancy and how to apply this information. Thanks.